Hi, my name is Saray McDowell, and my project this semester was on improving pending discharge compliance. So let's start with the problem. What is the perceived problem? Staff reported bottlenecking effect in the emergency department and lack of awareness of potential discharges on current inpatients. Appropriate planning for admissions and transfers were significantly affected. Bulk discharges were noted to be between 3 p.m. and 7 p.m. Reports from environmental services and the transport department were burdened with the bulk requests to clean rooms and transfer patients, hence ending up with delays for transporting and turnover of beds. When does a problem occur? Estimated dates of discharge is expected to be identified on admission. However, no proactivity amongst the multidisciplinary team to accomplish discharge date by expected date led to the breakdown of communication amongst the staff. So how do we know it's a problem? Patients were reporting long waits in the emergency room, including unexpected and unplanned patient movement on the units. Bed management also noted that the expected dates of discharge were not being satisfied. Information obtained from the teletracking data management system showed lack of utilization of the teletracking system. Quality management also presented the data to administration. Where does the problem occur? It occurs hospital-wide. To whom does the problem occur? To all disciplines, patients, and families. How big is the perceived problem? Confirmed discharge compliance was 55% when I started in January. This information was abstracted from the organization's teletracking system. It was reported that beginning of 2018, hospital-wide discharge compliance was as low as 37%. Long emergency wait times, including poor planning for beds, contributed to, again, the long emergency room wait times of over 48 hours. Due to this effect, the emergency department created overflow unit for patients who were awaiting inpatient beds. Not necessarily the best long-term solution. Potential causes of the problem: physicians, nurses, care coordination, transport, environmental services were not consistently using bed tracking and patient flow technology, therefore causing breakdowns in patient flow process. The teletracking system has always been in place. Even though training was provided, appropriate utilization of the system was minimal. Hence, also, no accountability was addressed. Potential resources needed to solve the problem. We're going to review over financial, structural, and human. Structural, well, the teletracking system to track compliance, it was always there. Why not use it? Why not continue to use it? Human, accountability from the chief nursing officer and the VP of patient flow was established. We did this to hold nursing directors accountable for staff to appropriately meet pending discharge compliance. Financial, no additional financial investment was needed at this time, as the system is already in place to be used. So, solving problems through interventions. Now we will talk about the different interventions that I helped implement within the organization with the multidisciplinary team. So we're going to just recap the project. So bottleneck and effect in the emergency department, poor patient discharge planning, lack of discharge awareness among staff, late bulk discharges, interdepartmental burdens and pressures. Evidence-based interventions. We educated staff in keeping teletracking up to date by inputting information as it comes in by designated staff members responsible to put in the data. Weekly metric reports were collected on pending and confirmed discharges from each unit. Breakdowns of pending versus actual discharges were obtained and collected and placed in a database to track hospital-wide compliance. We also ensured that the charge nurses were logged on to the mobile heartbeat, which is the company cell phone and alert program that we have via the cell phones to receive all bed assignments for reporting. So a very huge multidisciplinary approach was implemented in this project to proactively move internal transfers rapidly within a reasonable amount of time. Patient placement supervisor was doing daily rounding to reiterate the process with the charge nurses and the unit assistants to instruct them on how to enter the data. I have sent out weekly emails with a link learning video module on how to input the data. Weekly tier 3 huddles with administration on those low performance units so that we can identify challenges and reiterate the process. Monthly patient flow committee meetings were organized by service lines to discuss their particular compliance, current pending discharges, identify barriers and to rectify the issues, and also learning best practices from the successful units, kind of using the cross-pollination method. If this worked for this unit, what have they been doing on those units that can possibly help another unit that is struggling to meet compliance? So a lot of the barriers and challenges that I faced was within the 3 stages. We'll start with the planning stage. Participation from most affected units, hospital-wide, the lowest compliance units, environmental services department, the transport department and care coordination. Implementation stage, all disciplines, nurses, unit assistants, environmental and transport staff. They were hesitant to participate as they felt that using the teletracking system would be additional tasks to their current pressures of the job. And what I mean by current pressures of the job is that they felt that they were doing their due diligence by the current standard process. And of course, coming in and adding more meetings to their busy day, added more quote-unquote pressure to their daily tasks. One discipline also blamed the other discipline for delays, so it was a domino effect throughout the implementation stage. The evaluation stage, all managers provided with weekly compliance scoreboard. This is an email that I sent to them to see how their particular unit performed with the teletracking input and how it affected discharge and patient flow on their unit. Verbal report of teletracking utilization amongst designated staff, with unit clerk meetings and at tier 3 administrative huddles and patient flow committees were also done through the evaluation stage. The specialty units versus the med-surg units. Each unit has a very unique way of handling the teletracking system, but again, using the cross-pollination method really helped with bringing up the compliance on those lower performing units. Outcome evaluation, overall outcomes, the teletracking utilization increased by 12% in the 3 months that I helped to implement this project from January to April. The ED pull time has decreased by 10%. Units have begun to promote safe, timely, and efficient patient placement in order to enhance patient access. The interventions, again, supervisors did daily rounding. Weekly metric reports were collected and on pending and confirmed discharges from each unit. The breakdowns were provided of pending and actual discharges. These were obtained and collected and placed in a database to track hospital-wide compliance. Weekly emails, again, were sent by me to the nurse managers on all service lines every single Monday. And then the weekly tier 3 huddles with administration to discuss barriers and opportunities for improvement were done throughout the week at a change of shift so that we can have not only the day shift staff members, but also the night shift staff members. Here I want to show the pending discharge compliance. In January, when I started, it was at 55%. Actually, it started from week 1. You could see down the last column here, there's 51%, and slowly but surely it has gone up to 55%. And we have broken down each section by specialty. We have oncology unit, which is 4 units in the hospital. Cardiac units are 2. We have our med-surg units, neuro unit, surgery, and our pediatric units. The red numbers are when they are below the goal, and then the green numbers are anything above our goal. And now moving forward to April, I have up until April, the first week of April here. The pending discharge compliance has gone up to 67%. When you look at this chart, you could see there is definitely many more green boxes showing the compliances throughout the units and throughout the hospital. The unique role of the leader. One unique role of the leader was the development of the scoreboard. This scoreboard has definitely helped to show pending discharge compliance, as I have shown you in figures 1 and 2. These were broken down by service lines. I had described med-surg, oncology, pediatrics, and so forth. These reports were sent to the unit managers, the care coordinators, the vice presidents, chief nursing officer, and nursing directors, and these were sent out every single week. Upper management was expected to share this weekly scorecard with their staff during their Tier 3 huddles with their unit assistants at change of shift, again making efforts to attend meetings from day and night shift staff. Patient placement supervisor, again, rounded daily from unit to unit to offer education on inputting pending discharges in the teletracking system. This helped on holding accountability. Again, with the whole structural, human, and system processes. Visibility boards is something that I also created to feature on each unit to specify the metrics and the pending discharges. This actually helped in aiding with the discussion regarding the metrics during the nursing huddle shift meetings. So with the theoretical framework, I love the transformational leadership. I feel that this is a great approach towards this project. Again, I have dealt with multiple directors, multiple VPs from different specialties. In the planning stage, I will talk about how healthcare leadership has become an evolving sector in streamlining and improving patient outcomes due to cultural shifts, technological advances, cost of healthcare, and frequent policy adjustments. Various leadership styles have evolved to create a positive work environment and implementation of practices that lead to the best possible outcomes for the organization and its employees to meet its goals. During the implementation stage, with transformational leadership, the framework utilized for the outcome of this situation is to hold system process and key players accountable to initiate staff teaching on system usage, process, and organizational flow. Anderson, one of the articles, describes 5 themes of excellent nursing leadership. The themes described are characteristics in successful leadership, such as putting staff first, listening and responding to needs, getting to know the staff, and creating sense of community, supporting professional development, empowering and involving staff in decision-making, and being strong, visible individuals who are not afraid to jump in and help. During the evaluation stage, transformational leadership is critical to commit people to action, convert followers into leaders, and convert leaders into agents of change. In magnet organizations, leadership characteristics are integral to achieving clinical quality and patient care outcomes, though the creation of structures and processes supporting nurse empowerment and evidence-based practice. One who develops a strong vision of philosophy, communicates expectations effectively, and develops others and leads organizations to meet strategic priorities as a transformational leader. As my conclusion, educating the staff on using the systems within the organization and ensuring the charge nurses are held accountable for disseminating information will improve proactivity of all multidisciplinary members of the healthcare team. Attending monthly meetings to discuss process, ideas, gaps, and opportunities of improvement, again, multidisciplinary approach, will help in the continuation of improving quality of care. The weekly emails of scorecards, the Tier 3 huddle meetings with administration, and patient flow committee meetings are still in progress, as the organization has decided to increase pending discharge compliance goals to 90% by the end of the 2019 year. No matter where one works, whether it's in retail, banking, food, fashion, art, travel, or healthcare, when it comes to working, to the working environment, we have all heard and have verbalized the saying, it all starts from the top. It is safe to agree that attitude and energy level of managers directly affect the attitude and productivity of their employees. Lessons learned: multidisciplinary approach is needed to make a significant impact overall to major organization. This project was definitely all hands on deck, lots of communication with various nurse managers and supervisors and directors to strategically and patiently implement and educate the staff to come around and really make a change. Resistance to change, of course, was high, as the staff already felt burdened with the current tasks, but they did realize that after appropriate utilization of the system, it actually lessened the burden and increased compliance with the units. Always remain open to the suggestions, questions, and concerns. Everyone has great ideas, great questions, and we can always use a cross-pollination process amongst all units. Never blame the individuals. Always look at the bigger picture and fix system errors. It is always a system error once you really get down to the nitty-gritty. And lastly, but most importantly, patience. Patience, patience. This was a 3-month project, and as a saying, little quote there on the slide, patience is a key of element of success. Thank you very much.